Hello, I'd just like to continue the lecture where we left off in class. I'm sorry I didn't get to finish the material. I'm going to back up. I just want to back up a little bit. So, some of you um, may have thought I went through this a little quickly, and also in case you wanted to review it again because it's kind of complicated. I just want to go through it one more time. Absolutely, feel free to fast forward to the material that I didn't get to cover in class, and that'll speed things up a little bit for you. I want to go ahead and go through this in order, especially in terms of the way you'll actually see it in real life. So when you're basically your G cell and your D cell on, this is the antrum, this is the base of the bottom of the stomach, or the inferior portion of the stomach. The antrum has a lot more G cells and D cells than some of the other parts of the stomach. So the G cells will respond to peptides and actually the amino acids from the peptides in the proteins in your food. And the G cells are also activated by things like distension, so some pressure in the antrum there. The G cell will release gastrin into the bloodstream. Okay, so just imagine your mesenteric capillaries, or capillaries actually in this case by the stomach. The capillaries will carry into venules and things into the bloodstream. And this isn't anatomically perfect, but just the idea. I just want to get the idea here that the blood is flowing outside the stomach, in the body, and then eventually the gastrin will leak out of some of the capillaries closer to the body of the stomach, which is in the middle, and in the fundus, which is near the superior part of the stomach. Gastrin will leak out, and it has receptors on the ECL cell. Okay, it also has the same receptor on the parietal cell. In both cases, the ultimate outcome is increased acid secretion. On the ECL cell, that's mediated by indirectly by histamine release, and histamine activates the parietal cell through the H2 receptor. And then on the parietal cell, gastrin acts directly to through a regular general signaling pathway that I don't really want you to worry about the exact signaling pathway, but it does involve cyclic AMP, and that activates the proton pump to pump protons, also known as acid, right, into the lumen of the stomach. Okay. Now, obviously, the parietal cell looks a little bit different in real life. It's got kind of channels in it, channels that will have kind of kind of like a conduit, or kind of a zone here where the proton pumps will be around the entire membrane. And so there'll be a lot more proton pumps, obviously. Who knows, maybe millions of them or more per cell, something like that. But the protons will be flowing into a channel, and so it's not just one kind of indent here. It'll be a lot more than that. A few more crevices and things like that, but that's okay. You don't need to really know the details there. So acid is produced. This is the proton pump where our major drug class here, the proton pump inhibitors, would work. Okay, so that's gastrin. So gastrin is pro-acid, right? Gastrin is, so I have it red here. The G cell is red at least. Gastrin is the green, toxic green. So it's supposed to indicate negative, or bad or evil in this case, because acid is the problem in peptic ulcer disease. It's one of the big problems, of course. On the other side here, we have the the hero, or the protective guy, and that's the D cell. The D cell secretes somatostatin. Somatostatin I have here as this blue ball here, and it's going through the bloodstream, and it's going to come out again through the capillaries. So this is an endocrine effect because it reaches the bloodstream. It comes out of the capillaries, and somatostatin works primarily on the ECL cell, and that minus sign means it has a negative effect on whatever the cell does. So in this case, the ECL cell, right, that's going to secrete histamine. But when you inhibit, or when you activate actually the somatostatin receptor, that inhibits histamine release. So somatostatin blocks histamine release, and then that indirectly would affect then acid secretion by reducing the amount of histamine binding to the H2 receptor. That would reduce the amount of acid production. And I think it's really important to understand the relationship between the G cell and the D cell. The G cell is activated again through proteins. The D cell, in this physiologically makes a lot of sense. The D cell is activated when the pH gets pretty low, so the acid is high, and that makes sense because the acid would be high if we had a lot of gastrin activity. So the D cell fights against that, so we don't have excessive acid production. So the D cell will release somatostatin again and then inhibit acid. So one way it does that is it actually, the somatostatin from the D cell binds directly to the ST2 receptor on the G cell to directly block gastrin release. Again, and then that's the more direct and local, so that's much more local effect. And then the endocrine effect again is on the ECL cell to release histamine, or I'm sorry, to reduce histamine release. Okay. So a couple more things I wanted to talk about. One of them is some other regulatory factors. Something I don't want you to worry too much about, but this is, by the way, this is the relay from the central nervous system. What I have blue here, what I have as blue, that releases acetylcholine onto the muscarinic M1 receptor. I don't really want you to memorize these receptors for acetylcholine, but we have a cholinergic receptor on the ECL cell, cholinergic receptor on the parietal cell, cholinergic receptor on the non-parietal. This is a mucosal cell, and what we have is simultaneous. We have simultaneous stimulation of acid production. So we have stimulation of acid production on the parietal cell from acetylcholine. We simultaneously have production of mucus and bicarbonate from the mucosal cell. So what happens is, and this makes, I think it makes sense. So the physiology is that we'll have simultaneous acid production and protection. So all the cells that are not parietal cells will be protecting themselves with mucus and bicarbonate, whereas the acid is still, we could argue this point, but acid is to some extent physiologically relevant or important, partly to digest food, but also very important to protect against microorganisms and so forth. One more thing I wanted to mention is what I have in this blue oval here is prostaglandin E2 and I2. They're protective, okay, very protective, and please remember that it's not only that it's pro-mucus and pro-bicarbonate, which again that protects against the acid. It's also the EP3 receptor is here also on the parietal cell, and that suppresses or reduces acid production and secretion directly from the parietal cell. The problem is, as you see number 4 here, Nsaids. Problem is when we block cyclooxygenase 1 from arachidonic acid, we block cyclooxygenase 1. That blocks prostaglandin production. Blocking prostaglandin production blocks that protection. So again, the fundamental reason why Nsaids can cause ulcers is not really the direct effect on the luminal side of these gastric cells, but it's the effect behind the scenes on PGE2 and I2 to block their production. That will make the mucus layer too thin. We won't produce enough bicarbonate. Okay, and we also will have potentially more acid production. So that's really just about everything. Now all the drugs I'm going to talk about, or I'd say the majority of them, are shown down here with these numbers, and that's a big part of what you're going to need to know. It's all kind of on this one image, really big part of it. So H2 blockers or antagonists are working on the parietal cell directly on H2. That would be cimetidine, ranitidine, nizatidine, famotidine. There's so many of those. They're still available over the counter and not too rare. Of course, they're still used quite often. Anticholinergics, again, they're not commonly used for things like peptic ulcer disease because there are a lot of side effects on the rest of the body. Okay, a lot of non-specific effects. Misoprostol is not a super common drug because it has a lot of side effects. Okay, that's also pregnancy category X. I remember working in the retail pharmacy setting. The cap on the bottle of that would have a warning directly on the cap about not using in pregnancy. So it's very important to understand that. Um, it, it's in fact sometimes it's used as an abortifacient for women having abortions. So it's a very strong um, contraindication in pregnancy. But misoprostol, it does mimic these prostaglandins, so that means it does have a protective effect. And you know, from a pharmacology perspective, it makes perfect sense to give it when someone's on a COX inhibitor like any NSAID to counteract those. Now, in a realistic perspective, because of all the side effects, it may not be used as often as you might think. Okay, proton pump inhibitors, strongest acid suppressing drugs in the world. Okay, that's because they directly block the acid pump. They don't block a signal prior to it. They directly block the acid pump itself. So that really is a very direct way of stopping that acid pumping into the lumen. Sucralfate, you're not going to see the number anywhere in here because it would be working to coat the ulcers on a more broad, non-specific level, and I'll talk about that later. Sucralfate doesn't have a very specific target here. Bismuth and antibiotics, again, they're antibiotics you're not going to see on this diagram because obviously they're not working on the actual stomach, working on the microbes, and bismuth is working on the microbes, pathogens as well. Again, that's not having a very specific target, so that I'm not going to mention that too much more here on this image. Octreotide is number 8 over here. Octreotide resembles somatostatin. It's a little bit different. It is an octapeptide. That's why it's named that. But octreotide will block. Well, actually, it'll activate the ST2 receptor, which actually then blocks gastrin release, which is protective to reduce the amount of acid production. Now, octreotide has a lot of other effects in the small intestine and other places to block a lot of secretion of many, many different hormones, ultimately reducing fluid production and ion secretion and things like that. So I'm going to go ahead and move on. And we did go through this already, so I'm actually gonna skip this part because this part was probably not as complicated as the slide up here or the image up there. Okay, but just talking about assailants or what are the bad guys in peptic ulcer disease? Acid, pepsin. These are the obvious ones, right? Acid causes damage. Pepsin is activated by acid that can digest proteins in the stomach. It actually digests stomach cells if the mucus layer is too thin. H. pylori, very commonly found in the human stomach, okay, and a lot of other animals as well, a lot of mammals. Again, it's helix-shaped, several flagella, pH sensitive, it likes neutral pH, colonizes deep into the mucus layer near the gastric cells. I've actually read reports, articles that indicate that H. pylori can supposedly almost function like a corkscrew to kind of drill into the mucus layer and then get into the actual cells and damage the cells. So it seems to be kind of nasty in a sense. We already went through the colonization tools. So the highlights here that I think are really important is that let's look at these images on the right that H. pylori produces ammonia by breaking down urea that's already in the stomach. This urea is broken down into ammonia, which is alkaline. That alkalinity does some bad things for us and good things for the microbe. It protects the organism from our stomach acid. However, the problem with the ammonia is that it makes our antral region, if we have an antral infection from the bacterium, it makes the antrum more alkaline, and that will shut off the D cells. So if you look on the bottom here, this solid line with the arrow indicates good D cell activity, Normally we have good D cell activity, and if there's too much acid, it will shut off the G cell, so we stop that acid production. However, if we have H. pylori in the antrum, okay, in an antral gland, for example, which is what you see here up the top, the big problem there is, again, it makes just the local region alkaline, whereas the rest of the stomach will not be alkaline. So it gives the false impression that we're actually having an alkaline stomach. The false impression is given to the D cell, so the D cell shuts off because it thinks it doesn't need to work. Then the G cell has ungoverned or unregulated production of gastrin. That means unregulated acid production, and that's why antral infections in many cases lead to excess acid production. So that's why. So that we talked about the association, but this is not just association now. This is exact cause, okay, of that excess acid production. Okay, so some of the pathogenic factors that I want. So we talked about colonization factors. In some cases, they're overlapping, but I want to talk about the pathogenic factors. So what makes H. pylori really damaging? Okay, it causes direct damage to the mucosal membrane of those cells in the stomach. It has a toxin called cytotoxin-associated gene A. Well, that's the gene, but when the gene is expressed, it makes a protein called CAG-A that's associated with duodenal ulcers, atrophic gastritis, and gastric cancer. Again, H. pylori is one of the most common causes of gastric cancer from a pathogen. Okay, not gastric cancer overall, but gastric cancer from an organism or pathogen. H. pylori is a very common cause of that. Again, the ureases, remember the ureases produce ammonia. That causes problems with their acid production and enhances it. However, the ureases from the bacterium are also chemotactic, so they recruit monocytes and increase inflammatory cytokines. The H. pylori also produces lipases and proteases that directly destroys our parietal or other gastric cells, such as the D cells and things like that. So we have direct cellular damage from the bacterium. Even if we have a nice mucus layer, sometimes these bacteria can literally drill down in and colonize and bind directly to the epithelial cells. Okay, so back on this kind of maybe a little bit complex idea, hopefully not too bad. Again, the host gastric acid production, I want to talk about how it's related to where the organism infects the stomach. If we have an antral predominant infection, okay, we have increased acid secretion. Okay, basically we have, well, first of all, we have production of cytokines, okay, that are damaging to the area. We have production of ammonia. Okay, I don't really want to talk too much about the cytokines. I want you to focus more on number 2 here, and that's ammonia production is really what I wanted to talk about for the most part here. Ammonia production increases the pH, increases gastro, and that increases acid secretion. I already mentioned that. That's that masking of the acid to make the D cells shut off. So again, we have reduced somatostatin expression in antral D cells. When we have a body predominant infection, that's the middle of the stomach, we actually have decreased acid secretion due to infection-induced gastric atrophy. That literally means, maybe counterintuitively, that means we're killing the parietal cells with the organism, so we can actually have low acid and still have ulcers. And that's a misconception, I imagine, in the general public, that gastric ulcers are always caused by acid. In reality, it's proven now that the H. pylori can actually reduce acid production depending on where the infection is. Again, if it's in the body, then that's the case. Endogenous mucosal protectants against H. pylori. The thicker the mucus layer, the better protection against H. pylori. Okay. The epithelial cells are continually replaced by stem cells, so we have repair of the barrier and shedding of bacteria. So constant proliferation of the cells will shed the bacteria, and that's a good thing. Okay, I mentioned Nsaids, so I don't want to spend too much more time on that. Okay, The fact that the NSAIDs can be acidic, they are acidic for the most part. A lot of them have carboxylic acids and things. They can be acidic, but again, please don't make that misconception or have the misconception or conclude that they are toxic because they're acidic. They're much more toxic because they block mucus production. They block bicarbonate secretion. Okay, and that's the systemic effects. So as a pharmacist, you may be one of the few healthcare professionals that will know this, and you should know that if you give an intravenous NSAID, that does not mean that you don't have a risk for an ulcer from it. An intravenous NSAID can still have a risk, certainly a high risk of an ulcer due to prostaglandin inhibition. On the contraluminal or the basolateral side of the gastric cells. Okay, through reduced prostaglandin production and reduced mucus and bicarbonate production. And I didn't mention this in class, but this is I think it's very important that you have a combination that's kind of a perfect storm with NSAIDs. And I use NSAIDs quite often, but and a lot of people can do that and be fine for the most part. But some people do get a sensitivity in the sense that they form an ulcer. Yeah, they form an ulcer more easily than others, and the problem is if you do form an ulcer from and you're on an NSAID that caused the ulcer, or you're on an NSAID and somehow you have an ulcer from another reason. If it bleeds, the problem is NSAIDs are actually anticoagulants. Specifically, they're antiplatelet drugs. So they block, because thromboxane A2 is in the same pathway as prostaglandins. It is a prostaglandin. Blocking thromboxane A2 production actually blocks platelet activation. So you have a really big problem with bleeding in that scenario. Okay. So in terms of the pharmacologic agents used in the treatment of peptic ulcer disease, again, just going to get this guy out of the way. This guy's he's not hiding for me. I'm going to put him down there. Sorry about that. In terms of the pharmacologic agents used for peptic ulcer disease, we have mucosal protective agents. Sucralfate's an example of a mucosal protective agent. I have a maybe I could probably talk about it later on, but I do have a story about that I was recently prescribed that for something, and I very quickly realized the physician didn't understand how it worked. And just another example of why pharmacists are important. Sometimes the more we learn, the harder it is, because we realize these mistakes that are made. And basically, it was prescribed, and if you give that with a proton pump inhibitor, the problem is, and that's what was happening, the problem is it really won't work because sucralfate's only activated in the presence of acid. So the proton pump inhibitor would have suppressed the acid, and really sucralfate has no role in that case, unfortunately. And I don't really necessarily know that that's even in the literature and the guidelines, but it's logical because the sense that, what I mean is the sense that you're not really, it's not logical to combine sucralfate with a proton pump inhibitor because you don't have enough acid to activate it. But sucralfate is still prescribed more often than we might think because it's a really old drug. Okay, but it's a very interesting one to me because it's a lot different from most of the drugs we talk about. Sucralfate is an octasulfate of sucrose. Okay, so all these R groups are sulfates with actually aluminum hydroxide. Okay, all these R groups on here. In acid, specifically about less than pH 4, it becomes cross-linked. So it starts off, and I've done this experiment in the lab just to test it because we have it. It starts off as just a powder in liquid, and if you make the liquid acidic, it gets very gummy, and depends on how much acid you add. You can make it really kind of thick and gummy. You can make it more like flowing, so it flows a lot better. But it's a sticky polymer, so it's pasty/gummy. But the main idea that I want you to understand is that if you have an ulcer, sucralfate will coat that ulcer, and there's evidence that can help in some cases. if you don't have an ulcer, um, obviously it wouldn't make sense to use it, but I guess an example of a mistake, I suppose, it is if someone gave it, if you had, for instance, GERD or something like that, gastroesophageal reflux, but you didn't necessarily have an ulcer yet. Sucralfate really is not intended for someone without an ulcer. Okay. Next, again, is prostaglandin analogs, misoprostol. So I already mentioned that. Okay, so here's the details, and this is the structure of it. It looks very similar to prostanoic acid. Okay, prostanoic acid is really like your basic skeleton structure for all the prostaglandins. Okay, so misoprostol is very very prostaglandin-like, basically. And we have a lot of those, and the only thing that really defines them is their 20 carbon molecules with an acid on the end. This carboxylic acid in this ring structure here, and that's basically all your prostaglandins. We have many of them in the body, but misoprostol functions like PGE2 and I2 to increase mucous and bicarbonate secretion to protect us. H2 blockers, cimetidine, famotidine, nizatidine, ranitidine, just some examples. I don't necessarily have to go through this. This is just a review or reminder of how it works. Okay, but we're essentially blocking H2 receptors on parietal cells. And H2 receptors are actually the 3 receptors on the parietal cells that stimulate acid secretion. The H2 receptors seem to be the most important, and that's what's been reported. So blocking that does have some value, of course, significant value to it. Okay, and you can see on the right side here the structures. Might have to zoom in so you can see them a little bit better. Okay, the structures are quite similar to histamine, but because of the added functional groups and the size, they actually end up being H2 blockers instead of activators. Okay, and one thing I want to clarify here, because I didn't necessarily make the connection immediately as a student, but drugs like Benadryl or diphenhydramine, right, and fexofenadine, loratadine, things like the chlorpheniramine, all these antihistamines, these are antihistamines and those are antihistamines, but the difference is those are H1 receptors and these are H2 receptors, and the good thing is they're absolutely specific. So these are not going to cause drowsiness. These are not normal your normal H1. These are H2. Your H1 blockers are also not going to block H2, so they won't help for acid or anything like that. So they're very, very specific, so we don't have to worry about cross-reactivity. Okay, proton pump inhibitors. Well, there are many quote-unquote Me Too drugs in the proton pump inhibitors, and I don't know if there's any stop at or any light at the end of the tunnel there, or any end in my line of sight here. But we have all these oprazoles or prazoles, so dexlansoprazole, esomeprazole, lansoprazole, omeprazole, pantoprazole, ribeprazole, and probably some other ones. Now, just like a lot of other drug classes and a lot of other diseases that you might have seen or will see, we have enantiomers. So there's esomeprazole. Esomeprazole, that's just the S enantiomer of omeprazole, and omeprazole is racemic. Okay, so they might claim that that's advantageous. In reality, in many cases, it really doesn't matter, especially for proton pump inhibitors, because PPIs can block for almost 24 hours. Almost 24 hours they can block acid production, and really it's not necessarily critical which one you choose. In terms of the medicinal chemistry, I'm using omeprazole here as an example. Omeprazole has this structure, and you don't really need to memorize that, but what I want you to understand is that omeprazole and all the proton pump inhibitors are activated by guess what? Just acid. So that's an interesting situation. So we have a drug that is blocking acid secretion, but it's activated by acid. And it's a very, very unique mechanism, the way it works. And we're going to talk about that in a little bit of detail in a second. But I just first want to continue with the med chem here. It's converted to the sulfenic acid, and that's reversibly converted to sulfenamide. Sulfenamide binds to, now this is enzyme. Uh, Technically, I guess it's an enzyme because a proton pump is an ATPase. That means it's directly cleaving ATP. Okay, so that's the enzymatic domain. But what happens is this metabolite, the sulfenamide, covalently binds to cysteines, specifically on cysteines on the basically on the proton. You're not going to see that here, but because this is the drug on the left, okay, this is the sulfenamide on the left, and this is just saying enzyme. In reality, it's cysteines, and cysteines are what are forming your disulfide bonds in all your proteins. And what will happen is, and this is where it's really interesting to me, that the proton pump inhibitors, you can say they're not specific, but they are and they aren't. There's different ways of looking at it, because when you activate a proton pump inhibitor, it will bind to any cysteine that it can find. Okay, so if you activate a proton pump inhibitor, if you have a jar or a glass with proteins in it, albumin, hot dog protein, anything like that, any protein, and you activate the proton pump inhibitor with acid. You add some acid to that water, that will find any cysteine in its power or in its environment, and it'll bind to it, and and that's it. So what happens is, if you give that proton pump inhibitor, right, they're orally available. We give them orally. They're enteric-coated, okay? And the reason why they're enteric-coated is because if those drugs if they actually dissolve in the stomach, and this is going to sound strange, the proton pump inhibitors do not dissolve in the stomach. If they dissolved in the stomach, they would be activated immediately by the acid, and then they, instead of binding specifically to the proton pump, they'd bind to any protein available, any cysteine available on the proteins. So that could be a meal. If you had protein in your meal, well, your proton pump inhibitor will, and that'll be activated, and it'll bind to your meal food protein. If it's a mucosal cell, it might block a transporter or some other thing on the mucosal cell, but we want to block the parietal cell acid production. So the way that works is kind of interesting. The way that works is the proton pump inhibitor, it doesn't dissolve until it reaches the small intestine, and then it's nice and cozy, and it's neutral or alkaline. Then the enteric coating will dissolve, because that's how they work in alkaline conditions, right? It dissolves. Then the proton pump inhibitor gets absorbed in the small intestine. It goes into the bloodstream, so that's a really important thing to note. It's not a topical drug, and if it only worked on the stomach from the outside, that would be topical, right? From the lumen, but it actually goes into the bloodstream. It will eventually travel. It'll travel to the mesenteric, or actually gastric capillaries. Okay, the capillaries near the stomach. It will diffuse out. It'll go into, at some point, it'll get transported into the parietal cells, and it'll actually come out of the parietal cells. And I'm not sure that it's exactly defined how it gets out, but when it gets out of the parietal cell, it actually is, this is very interesting the way this works, and very fortunate in a sense. When it falls out of the parietal cell, it's going to almost immediately be exposed to all that acid, right? Because the parietal cell is producing the acid. So when it gets exposed to that acid, it gets activated immediately to the sulfenamide, and then it's going to bind into the first thing they can find that has a cysteine. And guess what? That is the proton pump, because a proton pump is what made the acid in the first place. So basically, the only reason why it's specific for proton pumps is because that's the first time we're allowing it to see the acid, is when it's near the proton pump. So we're masking it from the acid by enteric coating it as it goes through the stomach. Okay, so that's really critical to understand. It's a very, very unique mechanism there that's important. So if you a lot of you might happen to work in a hospital where you've had to compound. I've already talked to students who've had to compound one of these proton pump inhibitors, but they had to make it not okay. We're not talking about giving a patient the capsules or anything. We're talking about making a suspension or something for giving maybe parenterally. I'm sorry, not I don't mean parenterally. A suspension for giving maybe through a gavage or something in the stomach for someone who can't really swallow. What you might notice is because if you break it down and you dissolve the product, you dissolve the proton pump inhibitor, you'll end up combining it. They'll ask you to combine it with bicarbonate, sodium bicarbonate, because that bicarbonate makes it alkaline, and that prevents it from being activated, but it also protects it, but it prevents it from being activated in the stomach by alkalinizing the stomach in the first place with bicarbonate. So if you can't entericoat it, if you're not entericoating it, you better protect it by having an alkaline environment by giving bicarbonate. Okay, so I already talked about the enantiomers here. I'm going to go bypass that. Okay, so this is the mechanism. Like I already mentioned all this, so please spend the time to read through it in case there's anything else you can pick up from here, in case you missed anything. It's absorbed in the small intestine, blah, blah, blah. So it goes, I don't mean blah, blah. So basically this is all really important, but I don't want to go through it twice here. So I'll go ahead and move on, see if there's anything I might have missed. One of the things is, the time frame. It literally works. Many proton pump inhibitors will work for 16 or more hours. It takes, because it's a covalent bond with the sulfonamide, so the metabolite and the proton pump. So it's a covalent bond with those cysteines. So your cells, your parietal cells, have to produce new proton pumps to start functioning again. That's why it's such a long effect. Okay, and something that I like to look at that's quite practical is, so it's relatively kind of an old figure from an actual I'm pretty sure it's from a textbook, but it's really useful to understand that what's going on in someone's day with respect to their meals, their beverages, and with or without acid suppression therapy. Really useful graph we have here. So one thing I noticed immediately is if you look at this, if someone eats, the food will neutralize some of the acids. See how their hourly acidity, and this is kind of a weird unit, it's millimoles per liter instead of pH, but this is the concentration of protons basically. So the acidity goes quite low after a meal. Okay, and that's the black line here is actually your drug. That's your drug naive, or basically just your control with no drugs at all. So the pH goes down, or sorry, the acid goes down. Okay, the acid goes down, and then what will happen is after your meal starts to really get digested, your body's making a lot of acid to do that, so the acid goes way up. And then your beverage might slow that down, but then it's going to keep going up. Lunch, same thing. Dinner, same thing. Okay. So notice a light snack has a kind of minimal impact on that because it's not big enough. But a dinner or anything with a lot of substance to it can help to neutralize the acid that's already in the stomach, just very temporarily. So not for too long. So notice though, if you're taking first an H2 blocker, everything here is quite attenuated or suppressed. So after lunch, okay, well, first I'll say, actually before lunch, when you're starting to get hungry, you're getting more and more acid. Okay, this is going up and up and up, but it's much lower, much lower than without the drug on board. So one thing I really wanted to, just to speed things up, I wanted to just emphasize that whereas H2 blockers, they suppress acid, but you still see an obvious production of some acid, right? So, but just by this light blue line, you see there's an obvious production of some acid. If you're on a proton pump inhibitor, it's quite amazing actually. You have almost zero acid production for most of the day. Okay, almost zero acid production. Now, if acid is causing your ulcer, that could be very helpful. Um, if you're taking it's over the counter, right? These a lot of these are over the counter. If you're taking it very liberally and very um, yeah, and it's and you don't blame the customers, because why would they think an over the counter medication could be a problem so easily? But reality is, like I said, if you already have an infection, if you have an H pylori infection, making your stomach neutral by getting rid of as much acid as you can will actually help the organism grow, and that could help H. pylori colonize the stomach. There's absolutely proof that people taking proton pump inhibitors without antibiotics have a higher risk of certain gastric infections, um, and there are other issues that we can talk about um, in a little bit. So I just want to go ahead and go over some of the select adverse effects proton pump inhibitors. Probably something you might have predicted. This happens with a lot of different drugs. We get kind of the body trying to fight against what we're trying to accomplish. And one of those things is manifested here by hypergastrinemia when we have chronic use of proton pump inhibitors. And I don't know the exact time frame, but it's been shown that if we have kind of long-term use of proton pump inhibitors, or really any acid suppression therapy, the body will try to fight against that. And it makes sense if we understand that the D cells, as in dog, those cells are activated when we have high acid. And remember, that suppresses gastrin. Well, when we have low acid, the D cells will shut off from the proton pump inhibitor from producing low acid. D cells shut off, and then gastrin is released. If we never have high acid, again, because we're on a proton pump inhibitor, we'll have constant secretion of gastrin because there's no inhibition there. Constant secretion of gastrin does cause hypergastrinemia. Okay, and why does that matter? Well, the main reason is if you do abruptly stop your proton pump inhibitor therapy, even though it does last for about 24 hours, after that, hypergastrinemia can persist for some time, and you can get really excessive acid secretion. Okay, so that's about 5 to 10% of patients will have really, really high gastrin levels, which is about 500 nanograms per liter. Again, it's a hormone, so 500 nanograms per liter is actually a lot more than you might think. Okay, so you can get hypersecretion of gastric acid if you stop the drug. One thing that is quickly becoming very relevant in the world is, so it's surprising, so it took a long time to recognize this as a side effect or a problem. But proton pump inhibitors, there's a study that came out that proton pump inhibitors are now, they've been shown to be related to acute interstitial nephritis, or actually a cause of acute interstitial nephritis, and they're actually considered one of the most common causes of drug-induced acute interstitial nephritis. Now, just to temper the kind of concern a little bit, acute interstitial nephritis is not one of the most common types of kidney injury, but overall it's not one of the most common. But if you do have it, it's quite common for that to be caused by a proton pump inhibitor. Okay, and you could read the diagrams or the images here, the histology. It's really hard to see some of what the arrows are pointing to, so I'm not going to hold you responsible for any of that. Okay, but what I find is kind of interesting to see this is a real glomerulus, and it does look not too far from what the textbooks would look like, and very spherical looking, very, very round here. And I know from some of the research I've done, if you look over here, that's just a kind of cross section of probably a proximal tubule, so that it doesn't look very round. It looks kind of flat when you're actually looking on a slice. Okay, in reality, that's how it looks. And like over here, that looks like a tubule, another tubule, for instance. Okay, and I believe Dr. Calusi has some things to say about that, and I know he published something recently about that. Again, acute interstitial nephritis in general is not common, but you should be aware that proton pump inhibitors can cause this problem. And it's a little bit higher in general. in general, it's acute interstitial nephritis is a little bit higher in the hospital, hospital-acquired acute kidney injury. Okay, but just understanding the proton pump inhibitors, the two things I want you to to be concerned with and understand are that they can increase the risk of a gastric infection if you're not taking an appropriate antibiotic because of the neutralization of the acid, and proton pump inhibitors again can cause, and I don't know the exact mechanism, I don't know if anyone does, but they can cause this interstitial nephritis, where inflammation of not necessarily the tubular cells, but inflammation of the interstitial tissue with the fibroblasts and all the surrounding tissue around the nephrons, the kidney. These are some of the symptoms. I will not ask you about this on the test, just for your reference here, this third bullet, or the number 3 here, just some of the symptoms you would see. Okay, the problem is a lot of the symptoms are very nonspecific, so it's really hard to pinpoint and diagnose it. So that's why we have, of course, nephrologists, hopefully to help with that. Okay, and this is the time frame actually right here, anywhere from 1 week to 9 months after initial exposure. That means it can potentially happen after discontinuation, but really the risk is higher the longer you're on the proton pump inhibitor, basically like any drug. Okay. So something I alluded to much earlier, but I wanted to just to see, and I've alluded to this many times recently, but I wanted you to see the actual some of the evidence here. And this is from an old book that I have from I'm pretty sure I believe it's AstraZeneca. It's an old book talking about basically actually all the physiology of acid secretion, and it was actually made by the company that produced the first proton pump inhibitor, which is Prilosec. Produced this really nice book that I have, but they showed it was very, very unbiased, a very good book. What they showed was that H pylori, yeah, it grows better. Guess what? At a neutral pH, and that's the pH that you'll have if you're taking a proton pump inhibitor. So that is really strong evidence to indicate that you should not have a proton pump inhibitor on board if you have an H pylori infection, if you don't have an antibiotic appropriately targeting H pylori. Some of these drug interactions I don't want you to really memorize. This first point here, A, what I want you to understand is that so anytime you have a combination, if you have another drug on board, or you're administering another drug orally, and you're also suppressing acid, this could be a proton pump inhibitor, this could be an H2 blocker suppressing acid, but if you suppress acid, you need to understand that some other drugs can be affected by that. So again, if you have an enteric-coated drug, another enteric-coated drug, and you suppress acid, then that drug can potentially, actually almost definitely, start to dissolve earlier than it was intended to. So it might dissolve in the stomach in most cases. And so then some drugs will have changed bioavailability because of the acidity. Okay, so ketoconazole has reduced bioavailability, ampicillin antibiotic reduced, digoxin increased bioavailability. And I don't want you to memorize those because it's a little bit too much detail to memorize for compared to with all the other things we're talking about here, proton pump inhibitors. A few of the proton pump inhibitors inhibit CYP2C19. Okay, I want you to focus on anything maybe Dr. Calusi talks about with that. All proton pump inhibitors are metabolized by CYPs, and what I want you to understand though is when I said that proton pump inhibitors, so they're activated by acid, that's kind of a metabolism. They're activated by the protons, but completely separate from that is the fact that once they reach the bloodstream, the proton pump inhibitors they can be actually destroyed or metabolized in the liver, and that's one way of deactivating or removing them from the body. So that's a very separate activity or separate event from what happens in the stomach. Okay. So I wanted to spend just a little bit of time on on the pharmacogenomics. Okay, this is a relatively older article, but still quite pertinent. Pharmacogenomics, proton pump inhibitors Not too complicated, really. They're all PPIs are metabolized and inactivated by CYP2C19 in the liver after intestinal absorption or IV dosing. So I said don't worry too much about this, but and actually when it comes to the pharmacogenomics, I do want you to understand this, so I apologize for that. I want you to understand the pharmacogenomics. So that is, again, after intestinal absorption or IV dosing. Of course, regardless, you'll still get the liver at some point will get exposed to these PPIs and they will be metabolized. There are genetic differences in CYP2C19, and what they're called would be homozygous extensive metabolizer, okay, heterozygous extensive metabolizer, or poor metabolizer. That just means homozygous extensive metabolizer. That means you have two copies of CYP2C19 that are very active. Heterozygous means you have one copy that's very active, and poor metabolizer means you have two copies that are very low activity. Now, for the most part, the way this has been, the perspective that's been taken in the literature has been on efficacy, not as much on toxicity. So when you have poor metabolism of a proton pump inhibitor, if you give 100 people the same dose and 50% of them have poor metabolism, that 50% will have of course, a higher blood concentration, and there's actually evidence that they have higher efficacy for peptic ulcers. Okay, so one example is in Japanese patients, for example, they have the poor. It's more common, at least in Japan, to have the poor metabolizer genotype. Okay, and if you have the poor metabolizer genotype, if you look down on the bottom here, I mean in the diagram, we could look at three things that all go together. The area under the curve for the proton pump inhibitor is higher because you don't metabolize it as much. The intragastric pH is higher. That means it's working because it's more alkaline. The cure rate for peptic ulcer diseases is higher. Okay. Now, with this, again, more recent evidence of the potential renal damage from a proton pump inhibitor, we might want to consider, and I don't know that it's been done yet in the literature, might want to consider that not only would a poor metabolizer potentially better acid suppression, they might potentially have a higher risk of renal toxicity. And again, I don't know how extensively that's been studied yet, but it makes sense. So I'm going to go ahead and switch gears. Just again, check my time frame here. It's getting a little long. So you guys, of course, you can fast forward it to go through it a little bit quicker if you wanted to do that. But I'm going to go ahead and skip or move over to gastroesophageal reflux disease, or GERD. This is going to be a lot quicker. It should be a lot quicker because it's some of the same drugs, which I won't go over again, and just a lot less involved. The pathophysiology that I want to talk about, and one of the problems in GERD, or gastroesophageal reflux disease, is we have failure of the lower esophageal sphincter. That's also called the cardiac sphincter, which is above the fundus of the stomach. Okay, so it's above the right above the stomach at the bottom of the esophagus. If it closes, if it doesn't close completely, you can have gastroesophageal reflux. So that sphincter, again, it's a circular muscle. Like any sphincter, it's supposed to close. It's supposed to close completely when you're not swallowing. Okay. If we have that reflux of acid into the esophagus, that can cause erosions of the esophageal lining. That long term, I mean, it's probably tempting to think that if you have acid in your esophagus, it's just a nuisance. It might be painful, and you might not enjoy the feeling. But longer term, something much more significant can occur, and that's called Barrett's esophagus. And Barrett's esophagus is when the cell morphology, or the shape, changes from squamous to columnar. And that, I mean, we could say who cares, but it's just a tube, right? But it does matter because that indicates that we might be on the verge of getting cancer, or we're getting closer to having a cancerous growth or situation in the esophagus. So that's really important to understand, that acid in the esophagus is related to a cause of esophageal cancer. So please remember that. Now, I don't want to spend a ton of time. I added this, I think, last year because Dr. Calusi and I talked about it being important to talk about some of this stuff. But I wanted to talk about how some medications affect the lower esophageal sphincter. Okay, remember the LES, or lower esophageal sphincter, is controlled by acetylcholine receptors. Those are linked to calcium channel activation. Opioid neurons appear by an unknown mechanism to increase lower esophageal sphincter tone. That's kind of just a summary or an overview of what I wanted to talk about. So the opioids, we know they increase lower esophageal sphincter tone, okay, and we know they also increase anal sphincter tone. They also, well, they reduce bowel motility, but they increase the anal sphincter tone and the lower esophageal sphincter tone. So both of these types. Again, but they also impair esophageal peristalsis, kind of similar to the intestines, reducing peristalsis. Okay, it's poorly understood, so I don't want to talk much more about that at all. But it's kind of poorly understood. But we know that in some cases can help. Caffeine is typically considered a lower esophageal sphincter relaxing substance, which is bad for GERD. However, I just want to clarify something. Whereas caffeine, or I should say, while caffeine is considered bad in this case, there was a study in the New England Journal of Medicine that showed that it's not the caffeine that's the problem, and that's a misconception that's been going around for a long time, that caffeine is bad for your lower esophageal sphincter tone. And actually, they found out that decaffeinated coffee worked just as much as regular coffee or caffeinated coffee at lowering the tone of the lower esophageal sphincter. What I mean is, so that means decaffeinated coffee can also be a problem for people with GERD. So it means there's something else in the coffee that is causing the GERD, and we don't know exactly what it is. There are acids in coffee, there are oils in coffee, so we don't know exactly what it is, but very interesting that and that was actually an older study, it looks like, but that was interesting. Decaffeinated coffee's effects on the lower esophageal sphincter appears to depend on the method of decaffeination. Okay, and that's very strange. I don't want you to worry too much about that, but that means potentially different decaffeinated coffee may have a different effect. But what I want you to understand is that it's not the caffeine that seems to be the problem. It's just what's in the coffee beans other than the caffeine. So you can get a problem either way. Anticholinergic medications can relax the lower esophageal sphincter because acetylcholine is actually helpful to constrict the sphincter. So atropine is an example. It's a prototypical anticholinergic. Atropine, not used too often, but you might see it often in emergency medicine if there's a need to increase the heart rate. Again, that's increase the heart rate. But that can relax the lower esophageal sphincter. Generally, if someone's using atropine, we're not too worried about GERD because atropine is used in an emergency situation. L-type calcium channel blockers like nifedipine, nicardipine, all those can relax the lower esophageal sphincter. And there's evidence that the L-type calcium channels are important in lower esophageal sphincter constriction. Okay, that's all I really wanted to say about those. Okay, in terms of, so that was lower esophageal sphincter tone, but in terms of direct damage, I want you to understand bisphosphonates, and this is not it's not the first time, or I should say it's not the only time you're going to hear this, and you probably have heard it before. But bisphosphonates are for bone osteoporosis, stimulate bone growth, or actually prevent bone breakdown. Technically, the bisphosphonates like Fosamax or alendronate, they have a very strong warning that they can really irritate the esophagus, damage it. So they don't know exactly how that works, but that's why bisphosphonates, the very strong recommendation that you do not lie down, that you drink plenty of water after taking a bisphosphonate. The certain amount of time that you're not supposed to lie down, I think, is 30 minutes, but very, very strong damage, very high risk for damage to the esophagus. And some other things, aspirin, iron. I don't really want you to worry about those too much. Iron's a weird one. Some patients have seen iron, have had iron accumulate in the esophagus. Not really sure why that happens, but it's thought to cause damage because most metals can undergo oxidation reduction reactions and create free radicals and things like that. So that's potentially the reason. For the pharmacologic agents for GERD, of course we have antacids, and I really don't have a lot of complicated stuff here. Of course, they're pretty simple. Antacids are weak bases. Okay, they react with the strong acid, which is HCl, that produces water and sodium chloride or salt. Increase in pH due to antacids depends on the starting pH. So that just means um, it means that depending on the starting pH, you might have a higher or lower change in the absolute pH, and that's not something to worry about too much. But generally, it's considered that antacids are not very strong. They're not very efficacious compared to proton pump inhibitors or H2 blockers. But for a lot of people, they can help if you have temporary or transient reflux after a meal, even if you don't have a lot of acid. Antacids can help a lot to constrict the lower esophageal sphincter. And that's because alkalinization of the stomach, just by itself, just alkalinization of the stomach contents increases lower esophageal sphincter tone. And that's very, very helpful for a lot of people that don't have a major GERD problem. The available antacids are, we have carbonate containing baking soda. Actually, so baking soda contains sodium bicarbonate. Okay, so sodium bicarbonate, there's some small differences we have. That's more fast acting. Usually Tums would be calcium carbonate, more slow acting. Okay, so they have different rates of activity. They neutralize gastric acid, release CO2. You might notice if you happen to take an antacid like one of these and produce that CO2, you might notice more belching or burping after the antacid, and it is just about all CO2, so it might even be like, kind of like club soda or something like that, the taste. Okay, you can get whatever you don't belch up, of course, is going to potentially cause abdominal pressure and maybe flatulence. Okay, but usually we're talking about belching rather than flatulence. The bicarbonate and the sodium can be absorbed. That's not really good if you have renal dysfunction or renal failure, okay, because that means with the renal damage, it takes a very long time. It's very hard to remove electrolytes, so you don't want to really have any excess electrolytes. With calcium carbonate or Tums, there is a transient hypercalcemia, nothing to really worry about too much. We have magnesium and aluminum containing ones, so Myelantin, Maalox. Magnesium is fast acting, aluminum is slow acting. Okay, in some cases you'll have them combined. Okay, so for instance, Maalox, if you look at the name there, you can kind of imagine where the name came from. That's magnesium and aluminum. Okay, so if we combine a fast acting and a slow acting, we can get acute and sustained neutralization. So a practical benefit there. Magnesium, just a warning, magnesium is also a laxative. We can get osmotic diarrhea, even though we can use it as an antacid. We can potentially get osmotic diarrhea, a practical thing to say to a patient that might come over the counter with the over the counter medication and ask you about it. Just understand that it can cause diarrhea, and aluminum can cause constipation, the aluminum containing antacids. Sometimes they're combined, like I said, and they may have an offsetting effect to counteract the diarrhea and constipation effect. Not a guarantee, of course. We have something called magaldrate, which is Riopan or Riopan. That's hydroxymagnesium aluminum complex. It's absorbed very poorly, which is good, but in renal failure, which is very, very little filtration, very little GFR, you could still see hypermagnesemia and hyperaluminemia. Okay, drug interactions. Like I said, I already mentioned this. I think I want to reiterate it. Anytime you increase the stomach pH or alkalinize it, you'll cause premature dissolution of enteric-coated drugs. That may not matter. It all depends. If you're coating the drug enterically, if you're coating it for that to protect the drug, and then it opens up. If you're trying to protect the drug from the acid, then it may not matter because there's no acid left if it's suppressed. If you're trying to protect the stomach from the drug, and then the enteric coating dissolves prematurely, that could potentially be a problem if then the stomach gets exposed to the medication. So it all depends on the situation and the reason for the enteric coating. Aluminum and magnesium, and this is a very common warning that you see in a lot of places, that certain antibiotics can be chelated or bound up with metals like these, magnesium, calcium, aluminum, and things like that. So they can chelate drugs. Aluminum and magnesium can chelate drugs in the GI tract. And fluoroquinolone antibiotics seem to be one of the really common ones that you're not supposed to take those with antacids or anything that's going to have one of these cations, aluminum or magnesium or even calcium, because fluoroquinolone bioavailability will be reduced. Okay. Next one is alginic acid. You might notice on the left something strange there. That that seaweed-looking thing, actually, yeah, that is actually seaweed, and that's a brown seaweed. That's basically one of the sources. There are many types of seaweed that can have this, but that's one of the sources of this next drug called Alginic acid or sodium alginate. That's kind of an interesting one. If you look in the italics down there, you see that alginate is used in culinary arts to make, for instance, apple caviar and things like that. Just something kind of interesting. It's a dessert. It's a sweet that looks like caviar, but it's actually just kind of like a juice, basically, an apple juice that is gelatinized with alginic acid. It's isolated from brown seaweed. Like I said, it's got a polymer. Okay, it's polymeric chains of D-mannaronic acid and gluuronic acid formulated with sodium or potassium bicarbonate. So it's an antacid. We have an antacid in there, which is the bicarbonate, but the alginates precipitate in the gastric acid. They gelatinize in the gastric acid or divalent cations to form a gel. Okay, and the carbonate, which is in some formulations, produces the CO2, and what happens is the gas fills up the gel and it kind of creates a foam in the gastric acid. Now, so the theory here is that the raft of this gelatinous foam may act as a physical barrier to prevent acid reflux. For that to work, it should be taken postprandially or after a meal in an upright position for the maximum efficacy. And of course, for gastroesophageal reflux, we could always administer a proton pump inhibitor if we're getting, kind of an uncomfortable feeling from the acid, and especially to prevent that Barrett's esophagus, we could administer a proton pump inhibitor or an H2 antagonist or any other kind of indicated acid suppression therapy. And again, sucralfate, I mentioned briefly. Sucralfate creates that earlier. I mentioned that creates a pasty, gummy protective coating. Just like I said, it can coat gastric ulcers. Sucralfate can also coat esophageal ulcers. So if you have an open ulcer there, an active ulcer, it can coat that. And remember, though, sucralfate only really works in acidic conditions, so it really wouldn't work unless the stomach had some acid in it. So I find it very interesting. Actually, I think it's probably more common than I realized that it's administered with acid suppression, like a proton pump inhibitor, when in reality it's only going to remain as a powder until it finds acid, and then it's actually activated. Okay, so that wraps things up. Thank you for your attention, and have a great day or evening, depending on what time you're listening to this.